Hi, we are GRN, Team GRN, Global Rhinology Network. We are a non-profit organization with a mission to foster global education in rhinology and skull-base surgery. So we are on a journey to excellence. So we had our first episode featuring Cape Town. Now we are here for our second episode, which is
Pittsburgh, Centre of Excellence for Rhinology, so the place to be at the moment.
Absolutely, and it's not only the medical institute. Look at the building; it's amazing. The high rises with a very classical architecture. It's a great fun, and it's a lovely time to be here.
Yeah, the autumn colours are fantastic, really in the colours of Pittsburgh itself, in the gold and black, so should have a great time here for the...
On our way, we stop at this war memorial to the fallen soldiers. So we paid our tribute to them. These are the people who sacrificed their lives to keep us safe. I have with my colleague Rennie. She's a rhinologist and skull base surgeon from Imperial College Hospital Trust in London. So thank you, Kathy, for joining us.
It's a fantastic opportunity to be here. We're very lucky to be here at this time of year, and I'm very much looking forward to talking to everybody today.
We carry on further enjoying the beautiful sights of Pittsburgh on the way. Just arriving at the beautiful University of Pittsburgh School of Medicine campus and further towards the eye and ear.
So Ashok, who is going to be on top today?
I know, Kathy, who is on top of my mind, and that is UPMC eye and ear. So that's the anterior skull base surgery. Wow, it's such a privilege to be here. This is the birthplace of the newest subspecialty in ENT, anterior skull base surgery, and I can't wait to visit it.
Yeah, let's go and see what's happening.
Today we were going to discuss a little bit of some of the surgical anatomy, particularly as it pertains to the sellar and suprasellar space. We're always grateful to our fellows. There's one group of our fellows, there's another group now that produce a lot of these wonderful images that we use and have really helped to push the field forward in terms of redefining anatomy and then clarifying some of the nuances that are actually surgically relevant that help us make the surgery more effective, more safe, more accurate, as Dr. Roden used to say. So as sort of the landmark in endonasal surgery, the center of the universe, if you may, is the sella. Part of it's because we started doing endonasal surgery, starting to do pituitary surgery, and then expanded from there on. But if I had to see one landmark, if everything else failed, if I wanted to find one landmark and extrapolate all the other landmarks, that would be the sella. And of course, there's a lot of important aspects to it. There's a lot of important things around it, such as the choroid arteries, the cranial nerves, the optic nerves, the ACA complex, and so on and so forth. And it's a different perspective whether we look at it from below versus from when we look at it from above. It's all the same anatomy, but getting that dual perspective and understanding of the anatomy from both sides is particularly important for any skull-based surgeon. The endonasal anatomy tends to be a little bit more familiar to ENT surgeons. The transcranial anatomy tends to be a little bit more familiar with neurosurgeons, but again, it's extremely important to develop that 360 understanding and view that allows us to put everything together. So as we discussed, we start from the sella, and the sella is housed in the temporal bone, the sphenoid bone rather. We have the sella turcica, and we have the dorsum sella, which is the back that carries the two posterior clinoid processes. We have the anterior clinoid processes on each side, and it's a very small protuberance here, but we have what we call the middle clinoid. These are at the end of the sphenoid wing. We have a minor and a major sphenoid wing, and we have some important landmarks on the side as well that are also important for endonasal anatomy. We have the supraorbital fissure that, of course, carries all the nerves that are a continuation of the cavernous sinus on their way to the orbit. We have the foramen rotundum, and a little bit further lateral here, we have the foramen ovale, and that sort of defines the lateral corridor and the coronal plane of some of the approaches that we do endonasally as well. Of course, the sphenoid bone anteriorly articulates with the ethmoid bone. The ethmoid bone has a perpendicular plate that separates the right side from the left side, what we call the labyrinth. And I'm not going to say too much here, as I know our audience knows a lot more about this than I will ever do. But the superior continuation of this perpendicular plate is, of course, the crista galli, enlargement of this bony structure here that is important when we're doing, let's say, olfactory angiomas on an anterior skull-based procedure. We also have the medial and lateral pterygoid plates, and then we have this very stable relationship here of these two foramina that are at the base of the pterygoid, the foramen rotundum on each side, and then inferiorly and medially, we have this foramen here that's called the Vedian canal. And that's where the Vedian nerve comes out to the pterygopalatine fossa, and we can follow the Vedian back towards the genu of the carotid at the lacerum segment that we'll talk a little bit more about when we spoke about the posterior fossa, but then here we'll focus a little bit more about the cellular and supracellular anatomy. Of course, we all know that we have the soft tissue anatomy. We have an inferior turbinate, a middle turbinate, a superior turbinate, occasionally a supreme turbinate. The orbit comes into view and is very closely associated with the nose, as we know. Today, during the case, we were manipulating the medial rectus in order to be able to get to the optic nerve. Again, it's all the same anatomy, even though in a way they do belong to different specialties. Once we get behind the ethmoid labyrinth, we talked about the relationship here. There are many variations in how this is designed. If you think about it, I always think about it almost like a boat. When you look at a boat from the side, so it has this constant relationship, and sometimes it can be a little bit more flat. Sometimes this can be a little bit further apart, and in between the two, when we go past that, is what we call the lateral recess. Now, the keel or the rostrum of the sphenoid is a true midline structure, which is not the same as we go behind it with the septations. The septations actually are non-midline structures, and studying them on a preoperative imaging is extremely important to know exactly where they're going. If they're what we call nodal cells that may contain the optic nerve and therefore put it at risk for injury when we're drilling or trying to reduce some of the septations. So knowing the anatomy of the septations behind is extremely important, but it's very reliable unless there's a tumor displacing it, that the rostrum of the sphenoid is a midline structure. So you can always refer back to a rostrum to reorient if we're lost, let's say. We started discussing a little bit about the sphenoid septations. About 80% of the sphenoid septations will go back to the carotids. They will start a little bit more midline as we're further forward, but as we go back posterior, they usually will veer to one side or the other and go to the carotid arteries. So this is kind of the $1 million view or whatever currency you are used to. But it has a lot of important landmarks here. There's a relatively well aerated pneumatized sphenoid. It can be a lot less, for example, when what we'll call the conchal pattern, as you know, better than I do. But when we have landmarks, it's very useful, and there's no surrogate for anatomy. We tend to use, as you saw today, almost zero to very little image guidance during the surgery. We very much rely on landmarks, and as I said, if I had to find one structure, is if you find the sella, then you can extrapolate everything from there. So again, we have in the center, we have the sella. On each side, we have the carotid arteries. They're almost C-shaped, and they go back, and they're transition to the paraclival carotid arteries. There's, of course, the angiographic classification by epithelial area that we use on angiograms, but when we use it, when we are from an endonasal standpoint, we do use sort of an endonasal classification where we have a paracellular carotid arteries on each side. Now, very important landmarks, perhaps some of the impressive landmarks many times is this openings on each side, which are the lateral optical carotid recesses. And there are recesses that stand in between the optic nerves and the carotids. We have the optic nerves on each side, and in between them, we have what we call the prechiasmatic recess. So the prechiasmatic recess comes up towards us, and then in between the prechiasmatic recess and the pituitary gland, we have, of course, the tuberculum sella. Now, on each side of the tuberculum sella, there's another recess, which is not really a recess, but we call it such, that when we look at transcranially is the lateral aspect of the tuberculum, and it's what we call a spicule. So it sits in between and is nestled in between the pituitary, the optic superiorly, and the carotid artery. And it can be somewhat more difficult to remove, but it's also extraordinarily important if we are doing anything in the suprasellar space, such as craniopharyngiomas, or even more importantly, suprasellar meningiomas. You have to remove this little area that's called a medial optical carotid recess. So we have a lateral optical carotid recess. When we look at it transcranially, is consistent with the optic strut, which sits in between the optic nerve and the superior fissure. And we have a medial OCR, that's that little lateral aspect of the tuberculum that's nestled in between the optic, the carotid, and the pituitary. So very important, as we transition from the prechiasmatic recess superiorly in the area of the planum, there's this area here that's called the limbus sphenoidale. And as we transition from here to here, it's extremely important, even though it's a very short area, because we transition from the suprasellar space to the anterior cranial fossa. So it's important during surgery to have this X-ray vision that Dr. Al Roden used to talk about, is to know what's behind what we have. And of course, we know that if I open right here, we're going to see the pituitary. If we open in the area of the tuberculum, we're going to find the suprasellar space, which is subarachnoid empty space, if you may. There's arachnoid there and the superior epiphyseal vessels, but there's really not much else there. If I open right here in the prechiasmatic recess, we're going to see the optic nerves. But as we march up superiorly, if we open beyond the area of the limbus, the only thing we're going to see is frontal lobe. So if you're doing anything in the suprasellar space, there's really no reason to open further superior than the limbus. You can remove some of the bone to have some laxity to move the instruments around, but opening further here, it doesn't give us a whole lot more. So as we go further lateral, we have our optic nerves, we said. We have the optic strut or lateral OCR that separates the optic nerve from the superior fissure. The superior fissure is nothing more than a continuation of the cavernous sinus. So as we go posteriorly, that's the lateral compartment of the cavernous sinus that continues in the superior fissure. And as we go further inferior, we have another protuberance, which is the V2 prominence, which is a continuation of the second division of the trigeminal nerve, which, as we know, is not part of the cavernous sinus, even though it's in every copy of Netter and most of the anatomy books is actually outside the cavernous sinus. And in between the two paraclival carotid arteries, we have, of course, our clival recess, which are gateway towards the posterior fossa. Even just from here, we talked about some of the anatomy in terms of X-ray view. We know that if we open in the area of the sella, if we go all the way posterior, we're going to find the midbrain. If we open in the area of the middle clivus, we're going to find the pons. And if we're further inferiorly, we're going to find the medulla oblongata. So all the way back, we know we're going to find by opening. Of course, there as we discussed, variations in terms of the pneumatization pattern. Majority of the times, the lateral opticocarotid recesses are not as developed. Even this is a well-pneumatized specimen, but of course, sometimes we don't have as well of a pneumatized specimen. Something I meant to mention that didn't is that it's very commonly confused that the medial OCR, which again is nothing more than the lateral aspect of the tuberculum, as it points out as it goes a little further lateral, is a different structure than the middle clinoid that we mentioned a little earlier. And the middle clinoid, in a way, continues through the cortical clinoidal ligament with the tip of the anterior clinoid. We show some more pictures of that. But the point here is that the medial OCR is at the lateral aspect of the tuberculum. The middle clinoid lays in the C of the carotid, of the paraclival carotid, and it's a different structure. It lies just inferior and lateral to the medial OCR. And these are all the structures as we're looking at them from a transcranial view. Same exact structures. We have a posterior clinoids here, the dorsum sella. These are tuberculum sella that we talked about. And inside of it, you see how it becomes a little bit more prominent and almost it has a little spicule to it. That's the medial OCR. And I always tell our trainees, in order to remove a spicule, you have to surround it. So in order to remove that little spicule, there's a lot of work that needs to be done. We show a little bit during surgery today, but you have to expose a little of the carotid, you have to expose a little of the optic, you have to expose a little of the sella, and then that little area is going to come out. Otherwise, it's extremely hard, and you can actually hurt something. So again, medial OCRs are this area here, the lateral aspect of tuberculum. The middle clinoid is something different, which is just inferior and lateral to that, and it's a structure that actually leads into the cavernous sinus, and is connected to the tip of the anteroclinoid process with a ligament. It's called the cortical clinoidal ligament. It occasionally can completely calcify, and then can create a ring around the carotid. That's another thing that we need to pay attention to preoperatively on a CT angiogram, because if you try to remove a middle clinoid that's very thick and adherent, you can potentially avulse the carotid artery and cause unwanted bleeding. The other thing that's important here is that area of the limbus. The limbus, as we said, is the demarcation of the anterocranial fossa and the planum from the prechiasmatic recess. You see this recess here. It looks like as if the optic nerves were run through it, but they're usually actually not touching here. They're further posterior. It does depend on whether you have a prefixed chiasm versus a postfixed chiasm, what the distance is anteriorly or posteriorly. And of course, we have the optic canals on each side of that. But this here, again, if we open right here, we would see the frontal lobes are laying on the anterior cranial fossa. We talked about the cortical clinoidal ligament here, and you see how it's more developed. It's still not a complete ring here, but it can be even a solid piece of bone. That is the calcification of the cortical clinoidal ligament extended from the middle clinoid to the tip of the anterior clinoid. These are the middle clinoids. These are the medial OCRs, different structures. And of course, once we start putting everything together, we add the soft tissues to it. On top of that area that we call the limbus, and extending over the anteroclinoid process, we have the falciform ligament, which is a duplication of the dura. We did expose completely the carotid canal today, but if you really wanted to get to, let's say, an anteroclinoid meningioma, we don't do anteroclinoidal meningiomas through the nose because it's the wrong approach for it. But if you had a tubercular meningioma that had an extension into a clinoid, it's important to remember that there's a different layer of dura that's on top of the dura of the optic nerve. The dura that's, it's again, the two layers of dura over the optic canal. That's called the falciform ligament. So if you do that exposure that we did today, you can get further lateral and resect. Meningiomas are extending further lateral, almost towards the anteroclinoid there. So the diaphragma extends to the distal dura ring. There can be an invagination here that is a potential space for aneurysms in the paraclinoidal region. I always tell everyone that a good mnemonic to remember the course of the ophthalmic artery is to remember the ballerina. So just like a ballerina does this movement, it starts inferior, it goes lateral, and it goes up superior to the optic nerve, and then it gives the posterior and anterior sphenoidal arteries that we saw today. But it's easy to forget that. Once we remove the anterior clinoid here, this is the area of the lateral pterygocarotid recess. And here we have the carotid ocular membrane overlying the third nerve, etc. So again, putting everything together, the lateral OCR is the optic strut, the middle clinoid, the medial OCR, etc. We just talked about them. And again, the exposure, if you expose in the prechiasmatic recess, you will see the optic nerves. If you expose above the limbus sphenoidale, the only thing we'll see is frontal lobe. So in terms of exposures, we tend to expose always at least to the area of the cavernous sinus on each side. The majority of the times we'll do even more than that. That allows laxity of tissues when you're manipulating the tissues in order to be able to not have any restrictive movement. And although we don't necessarily open everywhere there, it's an example of a tumor that was originally resected and had some recurrence. And it was a tumor that was growing within the inferior intercavernous sinus and the carotid and the cavernous sinus. You see here the anatomy as involves. The area that I like to expose the carotid artery, you saw it today, is that anterior inferior area of the cavernous sinus. That's where the periosteum is separated from the adventitia of the carotid the most. That's how we remove the middle clinoid and then surrounding the medial OCR as well. You don't really meet the medial OCR here, so we're not completely removing it. In order to open into the cavernous sinus, we have to expose some of the floor because this area right here, this sliver in between the sella and the carotid artery is the safest area here. Because the tumor is growing purely within that inferior intercavernous sinus extending into the cavernous sinuses, we open a little bit differently, and we separate the tumor. You see the normal pituitary gland here. So I'm going to speed that a little further forward. This is a surgery foam that we pack the cavernous sinus with. We open it in a separate incision here in the cavernous sinus. You see that back cutting knife. That's very useful. When you have bleeding from the cavernous sinus, it is useful, even if you're not intending to go in it, just to make that opening a little bit larger so you can actually pack the cavernous sinus. And then we follow that C of the carotid up superiorly. The periosteum is separate from the adventitia of the carotid. It does get a little bit more dicey as you go towards the proximal dural ring. And then we medialize the medial wall of the cavernous sinus here, and then cut the cortical clinoidal ligament. That's what is attached to the middle clinoid and goes posteriorly to the anterior clinoid. It's the thickest ligament within the cavernous sinus. So if we medialize that, and then divide the inferior hypophyseal artery in order to separate it. We won't spend too much time within the cavernous sinus here. Let's see, this is the result of it. The orbits are, again, extremely important, and so is the anatomy of the third ventricle. In the third ventricle, as we go in the suprasellar space, I don't know what this is advancing, but we have the chiasm, the suprachiasmatic recess. We have the area of the hypothalamus, the mammillary bodies. We have the massa intermedia, and then after the hypothalamic sulcus, the hypothalamus, and the foramen mater, of course. One of the ways to expose the bone of both of the prechiasmatic recess as well as the tuberculum and planum is actually make osteotomies along the optic nerves and remove the bone from anteriorly to posteriorly. Occasionally, you may be able to flick it from posterior to anteriorly, but it's always easier from anterior to posterior. Again, the idea is to eggshell the bone in order to make it thin, and then instead of removing thick pieces of bone. Once we open the suprasellar space, of course, we have the arachnoid that's covering some of the microvasculature. And once we start clearing out that arachnoid, we see the branches of the suprahalveolar artery. So the suprahalveolar, in its most classic configuration, has 3 branches. There's a branch that goes up towards the optic chiasm. That's not you can't sacrifice that because in almost all likelihood it can be an impact on vision. There's a branch that goes up towards the stalk, and most of the blood flow to the gland is actually centrifugal. So most of the blood flow to the pituitary goes down the stalk and out the pituitary. A lot of the blood flow that comes from the posterior, the inferior visual artery, it actually doesn't go to the gland itself. It goes more to the dura of the gland and a little bit to the posterior gland. But most of the blood flow comes from the suprahalveolar. So if you do take any of those branches go to the stalk, that can be impactful. And lastly, you have like an inferior branch that mostly goes to the diaphragma. Many times actually useful to sacrifice that branch if you truly see it going to the diaphragma, as opposed to putting some of the other branches at risk. Many times when we work in the suprasellar space, you will have to make room somewhere, and it's a very tight space. So occasionally it is useful to actually go ahead and sacrifice one of them to avoid avulsing the others. Here's again the anatomy of the third ventricle, and then you see here some of the vasculature. Here are the posterior communicating arteries and the P1 segments of the PCAs, the SCAs. When we're working the suprasellar space, these can be at risk from pathology such as craniopharyngiomas. But these are extremely sensitive branches. You have branch of the anterocoroidal going back as well. We rarely get in touch with the anterocoroidal, but the posterior communicating artery is very much in play and can be injured. These branches. Once you're in the third ventricle, there's an anatomical specimen. This is from live surgery, but you see the columns of the fornix on each side. These are important memory pathways. The masses are intermedia, the intrathalamic adhesion, and the choroid plexus at the floor of the roof of the third ventricle, coming from each side of the lateral ventricles and going back to the posterior commissure, which is a connection between the two sides in the back, and then the pineal recess and the aqueduct more posteriorly. This is an example of a craniopharyngioma. Craniopharyngiomas, these are in a man that presented with dense hemianopsia. Craniopharyngiomas are intraaxial lesions. So although we go in this subarachnoid space, I do like to think about them as intraaxial lesions where you don't approach them through the subarachnoid space, but you approach them from within the parenchyma as well. He's raising the nasoseptal flap and the exposure. It is useful to expose some of the floor of the sella like we mentioned today. The reason for that is once you're working in the suprasellar space, you can actually depress the pituitary inferiorly to allow for a little bit of enlargement of that space because it is very tight. In the suprasellar space, there's barely room for the endoscope and any instruments. So every millimeter counts. And then by this maneuvers and gaining a few more millimeters by depressing the gland is usually beneficial. So once we expose in the suprasellar space, then we'll go ahead and open. Again, the way that we open is above and below the superior intercavernous sinus, coagulate and divide it, and then make cuts that go above the optic nerves to avoid the ophthalmic arteries on each side, and then some subarachnoid dissection. The dissection here is not extensive, again, because the only thing we're trying to do is expose the stalk and find an area where we can enter the craniopharyngioma. Again, my goal here is to develop some space and find the dissection plane between the craniopharyngioma and the interface with normal tissues from within, as opposed to start performing like an extensive subarachnoid dissection on each side, because that's not going to be the dissection plane. If you start attacking craniopharyngioma from a subarachnoid space, most likely you will start hurting the microvasculature that goes to the hypothalamus, to the optic nerves, to the optic tracts, etc., etc. So I think that it's always the best bet of trying to start developing this dissection plane from within and finding this peel-away plane that you can extrapolate subsequently up towards the hypothalamus. If you extrapolate this plane up towards the hypothalamus, the chances of causing significant hypothalamic injury is much decreased because you're not affecting the microvasculature. And that's most of the times what makes most of the morbidity is microvascular damage to the hypothalamus. So this is a postoperative course. In the supracellular space, there's other things that can live there as well. Here we go. This is another example of a tumor. Is a pilocytic astrocytoma, actually. Here, there's a little bit of a mid-transclival approach as well. But same premise is actually starting from the hypothalamus. And then as we go more further posterior, you can see some of the normal, this is the basilar tip, the third nerves on each side, the SCAs and the PCAs on each side. And this the floor of the third ventricle as it's being transparent. And then the aqueduct in the back. Again, removing the bone from anterior to posterior is useful. You saw how we remove some of the planum in order to make room for our instruments to be above the optic nerves. We never want to displace the optic nerves themselves. We're going to create space to work above them by displacing pretty much everything else other than that. Tuberculum cell meningiomas are extremely important. This is one that was encased in both optic nerves. You see that in extension into the anteroclinoid laterally. But these are tumors potentially that you can still tackle endonasally, particularly when they have all this exposure and extension of the tumor within the optic canal itself. And this is that case. Again, wide exposure and making a room above the optic, then opening within the tumor and performing the dissection. It's a relatively short tumor, but very sticky tumor as well. So the planes were not the same like we experienced in the case today, where we have a smaller tumor and a much better plane. You do have to work through some of the microvasculature, and then opening the canal goes way lateral into the optic here. You see how lateral it goes, both above in the optic canal. So working laterally. This is with angle endoscopes, working within the canal just above the ophthalmic artery, and making sure to avoid injury to the microvasculature as well as the ophthalmic artery that lays there. Going back towards the stalk, and again working around the supraapicial vessels. And you just have to be slow and methodical and take everything that's possible, and getting some dural margins as well. Is this one that actually improves very significantly. This is another endoscopic meningioma. We won't spend too much time with this. Knowing the anatomy of ophthalmic is very important. Many times you can have variations of the ophthalmic that can even go through the optic strut, or they can come through the canal here. So it's important to know some of the variations ahead of time, but also study the anatomy. This is an example of a case where we treated this patient with an ophthalmic segment aneurysm that was pretty medial. She was ineligible for any vascular treatments here because of the inability to take aspirin and Plavix. But you can see some of the anatomy in the suprasellar space around the ophthalmic artery. This is one that we exposed the cavernous sinus in order to get proximal control. Again, eggshelling the bone.
Hi, Kathy. That was wonderful. I mean, such a complicated anatomy, but he made it so simple and very, very beautifully presented. And putting the surgical videos along with the anatomy, that was anatomy lecture, that was really nice. So all osteology, soft tissue, and the surgical anatomy was covered. So brilliant. So can't thank you enough, Georgios. That was really great.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise. We're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB, or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.